Hello, everyone. Is the sound okay? Yes. Great, excellent. I'm really honored to be invited to speak with you today. Thank you so much. Is there an echo, or is it just me? Should I put that away? How's that? That's better for me, yeah. I really am so admiring of what you do for the department and so grateful. Thank you for the opportunity to speak. I'm going to be introducing you to the field of late life psychiatry, also known as geriatric psychiatry, and I'm going to be focusing on Alzheimer's disease research. When I trained in psychiatry about 35 years ago, there was very little attention paid to psychiatric disorders that occur when people age. And I'm going to use my time, my personal and professional story to show you how that's changed. I come from a family of many physicians. This is my grandfather, Joseph Donovan, who was a general practitioner and surgeon in northern Maine. He died at the age of 79 from heart disease and pneumonia, which were common causes of death in his generation. And this is my father, Thomas Donovan, who was a cardiovascular surgeon. Like many members of his generation, he survived heart disease because of coronary artery bypass surgery, but he later developed dementia and died at age 88. So I'm here today because my father had neuropsychiatric symptoms of dementia. Neuropsychiatric symptoms are the emotional and behavioral changes, the brain-based emotional and behavioral changes that accompany cognitive decline in dementia. They're tremendously difficult symptoms for patients and families. They often lead to emergency room visits and hospitalization and long-term care placement. During my father's life, he was very healthy, both mentally and physically. But as he had 7 children. He worked 7 days a week. He was an athlete and a musician and just a wonderful man, very involved in his church, and really loved life and lived well. But as he developed cognitive decline, his mental health also changed. He was frequently frustrated. He became uncharacteristically worried. He had distorted ideas that people were angry at him. And he was irritable, sometimes agitated. He lacked self-awareness. He expected to be in charge and make important decisions, but he was really incapable of that. And this was tremendously difficult for our family. At that time, I was in my early 50s. I was very experienced as a general psychiatrist. I recognized that his symptoms were psychiatric, but I didn't know how to treat them in the context of a diseased brain. Now, for perspective, there are about 5,000 geriatric psychiatry specialists in the United States, and there's over 7 million older Americans with Alzheimer's disease dementia. So it's really daunting for families to connect with the subspecialty care that they need. Our family was medically connected. We were lucky. We found a wonderful, older, experienced geriatric psychiatrist who helped our family guide us through this process, treated my father's symptoms, and in the end, we felt that we had provided the best possible care and life for him with the realities of his disease. And importantly for me and my siblings, we felt that we were able to maintain our relationship with him, each of us, until the end of his life. That was important to us, and we believed that that was important to him. So from that experience, I was deeply, deeply grateful. And I knew that I could help other families similarly, and I committed myself to this work. So at the age of 53, I retrained in geriatric psychiatry. I did research training at the Harvard School of Public Health. I trained at the Alzheimer's Disease Research Group at Mass General Brigham. And I was invited to become part of a newly forming study called the Harvard Aging Brain Study. I'm going to talk about that in a minute. And I started seeing patients at Brigham and Women's Hospital. I'm going to shift and just talk a little bit about what's dementia, what are neuropsychiatric symptoms, and what we've accomplished over the last 10 to 15 years. So dementia is a severe form of cognitive and functional impairment. It usually occurs as the result of a progressive, slowly progressive neurological condition, but sometimes it occurs acutely, for instance, because of stroke. And Alzheimer's disease is the most common cause of dementia. It accounts for about 60 to 80% of dementias. Neuropsychiatric symptoms can be grouped into emotional symptoms such as anxiety, especially worry, irritability, depressed mood, distorted thoughts in the form of delusions, often paranoid delusions, hallucinations, usually visual, and then distorted or disturbed behaviors, agitation, apathy, disinhibition, and sleep disturbance. Now, there are many reasons to be concerned about these symptoms. They are poor prognostic markers. They, for reasons we don't understand, seem to accelerate the disease course. But today I'm going to talk about the aspect of neuropsychiatric symptoms which have to do with the reality that they fracture the relationship between the person with dementia and their caregivers and their family. So these symptoms make it really impossible to take care of our loved ones at home. And there are both pharmacologic and behavioral treatments for these symptoms that really require subspecialty care. Hold on a second. Well, an example would be a patient of mine who was 79 years old. She was a sister of a senior colleague. She was a very successful businesswoman, but she had Alzheimer's dementia and had a syndrome called Capgras syndrome or the imposter syndrome. So my patient recognized the identity of her husband, but she didn't recognize the familiarity of her husband. So she misperceived him as being an imposter or being an intruder or into her home, and she would become very agitated for long periods of time. She would become combative. She would try and leave the house. This is actually a very common syndrome in dementia, and it's very difficult to treat because it's based on neurodegeneration of the brain and a loss of this network related to recognizing the familiarity of things. And this was happening during COVID, so we weren't able to hospitalize her. Her husband would try and leave the house for periods of time just to let her calm down, but that was unsatisfactory because she had dementia. So we were able to bring care into her home, a person who had some experience in actually previously working at an inpatient hospital. And because I had experience in general psychiatry and inpatient work, we were able to provide kind of high-level, assertive, but safe treatment for her at home. And I'm happy to say that many years later, she still is able to be maintained at home, and we were able to successfully treat her symptoms. But these symptoms really do require a certain amount of knowledge of evidence-based care, but then also improvisation because there's so much individual variability from patient to patient. So as I mentioned earlier, dementia is a state of severe clinical impairment. Alzheimer's disease is one cause. Alzheimer's disease begins 10 to 20 years before the onset of cognitive impairment. And this figure is showing slow declines in cognition and function along the dotted line. So Alzheimer's disease then starts at this preclinical stage, and this is the subject of the Harvard Aging Brain study that I mentioned earlier. So for 15 years now, we've been following 280 cognitively normal older adults. During this preclinical stage, people begin to develop the accumulation of amyloid and beta proteins, which are the Alzheimer's disease proteins. Just over the last 10 to 15 years, we've been able to image both amyloid beta and tau, so we can understand how these proteins spread across the brain and how they relate to the onset of clinical symptoms. So these brain images are showing amyloid beta accumulation in 3 different individuals. In the first set, in blue, these are from a person who's cognitively normal, who has very low level of amyloid beta. The middle panel is from someone who's cognitively normal but has high amyloid beta, the brightly lit signal. And then the third panel is from someone who has high amyloid beta and dementia. So what this is showing is that even among those who are cognitively normal, many people have high levels of amyloid beta. Actually, 28% of our cognitively normal participants in the Harvard Aging Brain study have high levels of amyloid beta. And that's been replicated in other aging studies as well. And these are the people that we're very worried about who are at risk of developing cognitive impairment. So the goal of the Harvard Aging Brain study and much of the work that we've done is to understand both the biology but also the symptomatology that leads from 2 important transitions. The transition from being cognitively normal but amyloid negative to becoming amyloid positive, and then that transition from being amyloid positive and cognitively normal to developing dementia. Now, my work has defined the onset of neuropsychiatric symptoms along with cognitive symptoms that occur in this early stage. We call these transitional symptoms because they tend to be kind of subtle. They're not full-blown symptoms. They certainly do increase in severity across stages of the disease, but they are measurable and they are symptoms of early decline. And on the right side is a snapshot of our research website that shows some of the symptoms that we have studied. We call them traditional symptoms. And then I've also been very interested in understanding more broadly the behavioral changes that occur at this very early preclinical stage. And I became interested in studying changes in social connection and social function. For instance, we found among cognitively normal older adults that had high amyloid beta, that had preclinical Alzheimer's disease, they were much more likely to report feeling lonely than those who didn't have those brain changes. And over actually a very short period of time, among those who were had high amyloid, we were also able to show declines in their level of social engagement. And this tracked along changes in cognition. So we're able to detect these very subtle incremental declines at a very early stage. These brain images show the relationship of Alzheimer's pathology to loneliness at the preclinical stage. So these protein accumulations in red are localized to regions involved in memory and in actually an area important to the processing of faces. Now, we know that social interactions help preserve cognitive function, and our work is suggesting then that there are occult or very subtle changes that are occurring in cognitively normal older adults. So we want to be able to detect not only subtle declines in cognition, but subtle declines in social interactions and other neuropsychiatric symptoms. And we want to be able to scaffold people to help them preserve their social relationship function and their cognition. So what has been the impact of this work? Well, some Our impacts have been intended and some have been unexpected. It was our intention to champion the non-cognitive dimensions of Alzheimer's disease that are so important to quality of life for patients and families, the social, the emotional, the behavioral features of the disease. And we have shown that they are associated to a large extent with the same pathologies that are associated with cognitive change. And we've shown that these are detectable as early as the preclinical stage. And that's been important because previously this dimension of Alzheimer's disease was really relatively unstudied and untreated. Now, it was my intention to understand and to demonstrate the relationship of social connection to cognitive function in older adults. But I really had no way of knowing how our studies would have as strong an impact as they have had. They've really been a major stimulus in driving research and clinical interventions in this area, in large part because of the COVID-19 pandemic. In the year before the pandemic, I was part of a National Academies committee and co-authored a report that reviewed the scientific literature on social isolation and loneliness in older adults and how that relates to the development of major health conditions such as cardiovascular disease, dementia, earlier mortality. And we also reviewed the state of the art of interventions for social isolation and loneliness in older adults. We released this report coincidentally about 2 weeks before COVID became apparent in North America and was declared a national health emergency. So this report really became an important resource for the healthcare community and a roadmap for me, frankly, in the work that I've done over the last few years. This report was also important because it was advocating for not only measuring social isolation and loneliness in a healthcare setting because of its important health impacts, but also partnering with community organizations to help alleviate this problem in the community. And then to follow that up, and this was during the pandemic, I partnered with another colleague and we co-edited and co-authored a textbook on loneliness and social connection. And this was looking at social connection across the lifespan, not just in older adults. And we also had special chapters on the problem of loneliness and social isolation in psychiatric disorders. So this was geared more towards healthcare professionals and particularly those in mental health. And following that up, now that we've had an integration between Brigham and Mass General, it's really been an opportunity for me to get to know and actually to already start collaborating with people at Mass General, not only in geriatrics, but in other fields to collaborate around interventions for social connection. Well, actually, the reason that I wanted to give this talk was my excitement about our accomplishments in preclinical Alzheimer's disease and now the advent of prevention trials, which I think are very exciting. So because of not only the work in the Harvard Aging Brain Study, but other sister studies in Australia and Sweden, others in the United States, the Mayo Clinic, we really do now, to a very large extent, understand the biology of preclinical Alzheimer's disease. Of course, there are things that we don't understand, but we really do understand the importance of these two major proteins, amyloid beta and tau. And not only that, but recently we completed the first prevention trial, which unfortunately didn't show benefit, but it was a very large trial. It was using an old anti-amyloid agent that actually wasn't very effective. And so we've learned a tremendous amount from that trial. And just recently, as you probably know, there was an FDA-approved medication for symptomatic stages of Alzheimer's disease. So we do have an FDA-approved anti-amyloid medication right now. So this is being used in 2 prevention trials that together are called the AHEAD study. And these two trials are targeting those two transitions that I told you about before: how to prevent people who are amyloid negative from becoming amyloid positive, and how to prevent the transition among amyloid positives from cognitively normal to cognitively impaired. And I just wanted then to kind of end with mentioning the biggest surprise to me, I think, or one of the biggest surprises, was to become to have the opportunity to mentor a tremendous number of young people who are very excited about entering this field. So we have drawn young people from all levels of education and training, undergraduates, medical students, residents, fellows, junior faculty, who are really inspired to do this work. It's very kind of inspiring to me. Many of them are drawn to this work because of family members with dementia, others because of the science being so compelling. But mostly, I think there is a huge kind of generation of young people who are very humanistic and very interested in being part of an effort such as this to try and solve like a major medical challenge such as Alzheimer's disease. And frankly, the reason that I've been able to do so much of this mentoring is because of philanthropic support from some of the patients that I've treated. It has supported the projects and the professional development of many of these young people. And as I was previously director of the Division of Geriatric Psychiatry, I started the program at the Brigham at the same time that we were starting a program at Mass General. And so we built a clinical team, not only in Alzheimer's disease care, but also in late life psychiatric disorders more generally. And this is kind of a passion of mine now, is to pull people into the field and to help their professional development. So thank you very much, and I look forward to talking to you later.